We start today with application of Freud to DSM-5. And before we do that, let us clear up a small ground related to DSM and see if we can take a look at alternate diagnostic systems. And with that opening up of our mind, we can go to chapter by chapter application of Freud. Uh, so DSM-5, as the name suggests, is a diagnostic and statistical manual. So essentially, it's a diagnostic manual. It's a descriptive manual in the sense it describes a disorder. It does not go into the causality of the disorder. It does not go into the prescription of the disorder. It essentially describes a disorder. So it's descriptive. Third characteristics is it's theoretical. In the sense it does not follow Freud or Jung or even neurology or anything else in terms of causality. So in terms of causality, it's theoretical. If we look at history of DSM, we can start with DSM-1, DSM-2 and come to DSM-5 TR today. DSM-1 and DSM-2 were largely influenced by psychoanalysis. So they had psychoanalytic terms like neurosis, psychosis, and so on. After DSM-2, there was a very famous study called Rosenfield studies. And that study found that the interpretation of DSM was very subjective. And the same patient can be diagnosed very differently by two different psychiatrists using the same DSM-2. And that brought about a need for having an objective clinical data-based criteria to diagnose a disorder. And that is how DSM-3 came into being. DSM-3 essentially adopted a cluster characteristic approach, meaning you give a set of characteristics, 10 characteristics, and then you say, out of this 10, if the patient has 5, he can be diagnosed. If he has 4, he cannot be diagnosed. So you have a number of criteria characteristics and then a qualifying number that if you cross this number, you can diagnose it. That broad approach was based upon clinical data. It was theoretical, causal, and it was not into prescribing anything. It was only in terms of diagnosis of the disorder. DSM-4 and 5. DSM-4 and 5 DSM-4 and 5 largely continue with the same framework of DSM-3. There are, of course, changes. Like in DSM-4, we had a very popular thing called diagnosing on cluster A, cluster B, and all those kind of things. Axis 1, axis 2, overall universal global functioning of the personality. Those characteristics, those parts have receded in DSM-5. So there were changes, but if you look at largely the structure, DSM-4, DSM-5, DSM-TR, they still broadly function in the same cluster characteristic approach of DSM-3. So now let us look at some alternative diagnostic systems also. So if we look at DSM, we will look at, if you put all the disorders described in DSM together, you will be looking at a number of 150 to 175. That will be broadly the range of disorders given in DSM-5. Maybe plus minus 10, I'm not very accurate, but what I'm just trying to put across is it's a small number. We are not dealing with thousands or lakhs. That we are dealing with 150 to 175 disorders, and you can organize these disorders very differently based upon different criteria. What DSM follows is cluster characteristic approach, where a cluster of characteristics and a defining number of how many criteria are met, they are used to define a disorder and qualify for a disorder. So there is a name given to a disorder, and there is a qualifying set of criteria to be met for anybody to be diagnosed for the disorder. So there are two very important things, the naming and the qualification. And this qualifying criteria are coming from clinical data. They are not coming from a blood test. They are not coming from a CAT scan. They are not coming from any investigation, pathological investigation of the conventional kind. They are coming from clinical data. And then once you name a disorder and you define a qualifying criteria and the qualifying number for a disorder, then you collect those disorders into chapters. And that is how you put together DSM. So this is the broad approach of DSM, where clinical data is at the root of naming, diagnosing, and organizing disorders. So you see this 150 to 175 disorders are organized in practically 22 or 23 chapters, out of which 4 to 5 chapters, or almost 6 chapters you can say, are biologically heavy in terms of causality. And the other 16 to 17 chapters are where we can do a lot of good things. So we will focus on those 16 to 17 chapters of DSM, where therapy can play a central role. In other chapters, in some of the chapters, we may not be able to play any role, and in some chapters, we can play a marginal role. But in 16 to 17 chapters, we can play a central role along with medication, and that we will discuss. So this is one diagnostic system, DSM, a theoretical, a causal, not going into prescription, going into naming, qualification, and organizing of disorders on the basis of clinical data. Now, second diagnostic system you can have of psychoanalysis. And in the history of psychoanalysis, the diagnostic system has undergone changes. The first way Freud described all sicknesses were neurosis and psychosis. So, in psychosis, there was a break with reality. What we call reality testing was impaired. In today's language, we will say reality testing was impaired. In those times, it was said that there is a break with reality. That was how it was described. So the first diagnostic system in psychoanalysis was neurosis and psychosis. Then people realized, in fact, Freud and his disciples realized, because they were the only ones who were actually originally creating the whole area, that some people have characteristics of both neurosis and psychosis. So in those days, they were termed as borderline, which is very different from how we use the word borderline today. Today, it is a disorder. At that time, it was a category word to cover a range of disorders which showed some features of neurosis and some features of psychosis. Later on, as borderline came to be acknowledged as a disorder into itself, again we came back to the same old idea of neurosis and psychosis. Because now we realize that we are using the word borderline for a very specific disorder. So we are no longer using that as a category term. Now, if you look at Lacan, he has a different diagnostic system. His diagnostic system is neurosis, like we know, psychosis, which is a break with reality, and third, he introduces perversion. Perversion meaning you cannot observe the do's and don'ts of reality and morality. So he puts all disorders into three. For example, if we put all one 175 disorders of DSM-5, in the psychoanalytic diagnostic system, they will be largely categorized into two: neurosis and psychosis. So you will have part 1 neurosis, part 2 psychosis, and then you will have subparts of part 1 and part 2. Similarly, if you use Lacanian diagnostic system, you will have to classify all these 175 into neurosis, psychosis, and perversion. If you look at CBT, they will put into 3 categories: disorders driven by I am not good enough, meaning self-worth related disorders. Second, I am not lovable, meaning attachment problem related disorders. And 3, the world is not a safe place, meaning positivity, trust, and catastrophic thinking driven disorders. So you'll have to divide all the 175 into 3: part 1, part 2, part 3. And then, of course, part 1 can be subdivided into anxiety related disorders, obsession related disorders, and so on. So we can see that we don't have only one diagnostic system, but multiplicity of them. What has happened is DSM-5 has come to become the consensus diagnostic system, and the language of DSM-5, the naming of disorder, the qualifying criteria, and the organization of disorders, that has come to be accepted by everybody. So this creates a common language between psychiatry and psychotherapy. So today in all schools of psychotherapy, they will be teaching DSM-5. One of the subjects will be DSM-5. Any questions on this? So now let us look at the causal nature of the descriptive systems, diagnostic systems. Diagnostic systems can be descriptive or causal. DSM is a descriptive system. It's a causal, a theoretical system. In psychoanalysis, essentially we look at causality in terms of what each school of psychoanalysis talks of causality. And therefore the difficulty is, if we bring in causality into a psychoanalytic DSM kind of thing, we will have a Freudian DSM, a Freudian psychoanalytic DSM, we will have a Kleinian psychoanalytic DSM, and so on. Because each school has its own take on the causality of any given disorder. So if you say delusion of persecution, Klein will have her own causality, Freud will have his own causality, and so on. And obviously, we get patients of all types. We are not going to get only Freudian or only Kleinian patients. We have patients of all types. Now, in terms of Lacan's diagnostic system, he talks of the causality in terms of the core unconscious process which is used and central to that category of pathology. So when he talks of neurosis, the core unconscious process is of repression. That repression is the core process which is behind this entire category of sicknesses. And this will cover, let us say out of 175, this will cover almost say 120 sicknesses, disorders. In psychosis, Lacan says the core mechanism is foreclosure. What he means is, we'll not go technically into what he says, but what he says is foreclosure of the name of the father. But what it means in simple language is, before the constraints of reality and morality could be internalized by the child, something happened and that process stopped. And he was not able to fully internalize the constraints of reality and morality. And perversion is, he refuses to accept reality and morality constraints. So the core process there is disavowal of the do's and don'ts of society. So if you talk in terms of Freudian language, you will say neurosis, the core mechanism is repression, where there is too much castration. So there are too many desires wanting to come up, and there is too strong a control, too much of repression of desires. So metaphorically, we will say too much of castration. Simple language, there are too many desires and the control is too strict, and too much of frustration of unfulfilled desire which is inside. In metaphorical Freudian language, we will say there is too much of castration. Castration here means not literal castration, but a limitation put by reality on the movement of our desire. That we want a free for all ground for our desire to move wherever it wants to, but reality and morality puts a limit to it. And that limiting of the movement of our desire is what is termed as castration. It's a metaphorical understanding of the word, not the literal cutting of the penis or scrotum. So the second is foreclosure. So here in psychosis, constitutionally, the person is incapable of accepting limitations. He may even want to accept limitations, but is incapable. So in repression, there is too much castration. In foreclosure, the person is incapable of castration. Even if he wants to accept castration of reality. And here, metaphorically, we say castration. So we say, if we have to remain sane, we all have to accept castration by reality and morality. We have to accept our desires being limited by reality and morality. We have to accept that castration to be sane. So here, even if the person wants, he is incapable of castration. The personality just doesn't have the resources, the capability to accept castration. In simple language, we will say the sensitivity and the desire are too strong for the control of the ego or the superego. And the third is perversion, where the personality refuses castration. It's capable of it, but refuses. And therefore goes into perverted acts. So it's not that the person who is committing perverted acts does not know what is right and wrong. He refuses to accept the boundaries of right and wrong. So he is capable of healthy castration, but he refuses it. So the mechanism there is disavowal. And in terms of CBT, the causality is I am not good enough, I am not lovable, the world is not a safe place. So entire 155 disorders have to fall into these three in terms of causality. So once you choose a system, then you can't say that why these things have to converge there. That's the given of the framework of the system. Any questions here? So now when we apply Freud to DSM, how does it look? If we take a total of 150 to 175 disorders, removing those which are biologically driven heavily, then the rest of it we can apply Freud to. And in terms of causality, what are the elemental causes that Freud talks about in his entire work? So let us revise what we have learned till now. Freud talks of component instincts, right? If you remember, exhibitionism, sadism, masochism, voyeurism. He talks about the structural model of the mind, which talks of conscious, unconscious, ego, superego. So in component instincts, you have 4 component instincts. In structural model of the mind, you have 3 structural agencies. In psychosexual stages, you have 5 stages. And in those stages, something can go wrong. Freud's later model is of life instinct and death instinct, eros and thanatos. So we have 2 elements here, eros and thanatos, life instinct and death instinct 2. So if you put all of this together, you will come to a total of 20 elemental causes or a combination of them. So the entire 175 or 150 disorders have to be explained in terms of causality by these 20 elements or their combination. Within the Freudian framework, you can't go anywhere else. So this is the way we will go about it. That, for example, somebody has a conduct disorder, let us say of some sort of voyeurism or something, we will say the component instincts have not got organized under the overall genital organization. It is still free on a standalone basis. When we talk of, say, perversion, we will say the ego and the superego are not able to hold back in terms of this. In terms of psychosexual stages, if we talk of narcissistic personality disorder, we will say something has gone wrong in the oral stage. So we'll talk in terms of what happens in terms of stage. So if somebody is extremely suicidal and we can't find any reason for it, and we don't even see very intense anger, and then we say that perhaps the death instinct is too strong. Or we say the life instinct is not able to neutralize the death instinct. There is a decoupling of the two. They are not coupling together. So this is the way we will give explanations. As we go along, it will become clear. Now, what are the problems? Obviously, yeah, please.
What are the 4 component instincts? I forgot.
Sadism, masochism, exhibitionism, voyeurism. We had talked about it, that these component instincts then come together and get organized under the overall genital organization. So when the person becomes, after puberty, when the person starts becoming an adult, all these 4 components are there, but they get organized under the broad arcade of adult sexuality. Like in adult sexuality, you will find all the 4. For example, everyone likes to see pornographic movies. That's a classic example of voyeurism at work. That we want to see somebody else doing it, and by identification, we want to enjoy. So that is voyeurism. In a non-sexual context, it will be wanting to know what is going on in others' lives. Sadism, masochism, we know about. And exhibitionism is showing oneself off, the sublimated form of which is the desire for fame, or the desire to do any kind of show off. Like I buy a big car and I take it to a social function. That is exhibitionism in a sublimated form. I get my photograph published in a newspaper and then I show the newspaper to everybody. These are our more subtle forms of exhibitionism. So they are the component instincts, and they come together, and initially they are standalone, but they come together and get organized under a broad adult sexuality, usually at puberty. In Freudian language, genital stage. So now, what is the school problem? The school problem is, obviously, every patient who comes to us is not a Freudian patient. So we need multiple schools to really do justice to different types of patients. So there is a limitation of the Freudian school. Now what happens is, if somebody knows only Freud, then he will try to force fit a causality. So he will try to explain in terms of Oedipus or oral stage or anal stage, where that is not relevant. Let me give an example. Say, delusion of persecution. 2 people come with the same problem, delusion of persecution. Both of them have the same fear that somebody is going to come and attack me. and therefore they cannot go out. They hide behind something, and all the things go on. Now, one person may have it because of repressed homosexuality, where Freud becomes applicable. And the second person can have it because he's projecting his aggression out into the world, and then he's fearing the same aggression. That he projects his aggression on an imaginary figure or a real figure, and then he fears that figure is going to attack him. Now there, the Freudian explanation actually is not the correct explanation. The Kleinian explanation is the more correct explanation. But if you don't know Klein, you will try to force fit Freud in some way. So this is the difficulty and limitation of every school, that every school is limited and cannot provide a correct explanation for all groups of patients who come to us. So we have to find out, first know the different schools and then find out which patient belongs to which school in terms of causality. And when you take case history and when you look at the details, it's not impossible to find out. Most of the times we can. In some cases, we may need more time and maybe a few therapy sessions, but we can find it out. So there what happens is you are trying to heal what really you don't understand. That you have a Kleinian patient and you are trying to heal him with the Freudian method, Freudian concepts, Freudian technique of psychotherapy. And it's not working. What will happen is the generic healing parts of any therapy process that will work. For example, in any therapy process, there are two parts: a generic part, a school-driven part, and the therapist-driven part. There are three parts of what heals. The generic part is that you provide a confidential, safe place to anybody, and the person can figure out a lot of things for himself. He can lighten his chest and let go of things he has never spoken of. He gets support and empathy for probably the first time in many cases. So these are the generic healing components of any therapy, regardless of which school you follow. So this generic component will always work, whether you are a Freudian or a Kleinian or anything else. That every therapist will provide a safe space. Every therapist will provide amoral, uncritical listening. Every therapist will provide safety. Every therapist will provide containment. Every therapist will provide a good, reliable, stable object. Every therapist will provide a discipline of coming to the same place, same time every week, and focusing only on inner problems and not anything else. Every therapist will encourage the person to speak out what he cannot speak out anywhere else. So these are generic healing parts of any therapy. After this, the school component comes. And after that, the unique therapist component comes. So the first component always will work, but then you will enter into a stalemate, into a limitation, if you are into the wrong school. So you may end up in trying to heal what really speaking you don't understand, but you are trying to force fit a causality and force fit a method to solve a problem. And that is where a very important component in practice comes of supervision. That if by chance you choose the wrong school, wrong causality and wrong technique, and you see after a few sessions that nothing is moving, and when you encounter that stalemate, and we all encounter in our practice, it is best to take supervision. Take the transcript of 1 or 2 sessions, or if you can video record, in some cases you can video record, and take to a supervisor. And there are two types of supervisors. One is general supervisors, who are just seniors in that area, who have done more than we have done. And second is consultant supervisor. Let us say, for example, I go to a supervisor who is very good in Freud and in Kohut, but he is not very good in Klein. So what he will do is he will tell me that for this particular case, you need a Kleinian supervisor. So those supervisors we call consultant supervisors, where one off we go. So we have a general supervisor and a consultant supervisor for a very specific particular cause. Like for example, you realize that the person has Oedipus, but we don't know what question to ask and how to start a conversation because the man is refusing to start a conversation. So then a Freudian supervisor is good. Okay, we know the Oedipus is at work. How to start a conversation without offending the person and what interpretation to make based upon what he says. So we can have a general supervisor and a consultant supervisor. Okay. So now let us go to DSM-5. We will start with Freud. After completing Freud, if we go to Klein, we will again come back to the same DSM-5. And we will say, let us apply Klein to the same chapters and see how we get a different explanation for the same disorder. And after doing 2 or 3 schools, we can consolidate and we can say that generalized anxiety disorder patients we can classify into 5 groups. The Freudian causality group, the second group where the Kleinian causality is at work, third group where the ISTDP is at work, fourth something else, and fifth maybe we don't understand what is at work. Because all the schools that we know don't give a convincing explanation. So we might end up in that group also that we don't know. Probably in future, new schools will come and they will explain. So this is how we will do. At present, we will do the Freudian interpretation. So what we will do is we'll take up a chapter. We will have a broad Freudian discussion on the chapter. Then we'll take up a disorder, have a broad Freudian thing, and then we can go symptom by symptom that what analytic process will be behind each of these features. For example, in depression, there can be a feature, too much or too little sleep. Too much or too little diet. So what will be the unconscious process if we are looking at a depression where we see too much of sleep? And what will be the process if we see depression where there is too little sleep? So when we see too much of sleep, usually it will be a sadness-driven depression. When we see too little sleep, we will usually see aggression, anger-driven depression. In anger-driven depression, we have to be more careful about suicidal ideation. The chances of the idea converting into an attempt is much higher than the sadness-driven. Okay. Let us go now to DSM. Okay. So we will start with chapter 2. Chapter 1 is very bio-heavy, neurodevelopmental disorders. So we'll start with chapter 2. So let us have a general discussion. We are talking about break with reality. Psychotic disorders, schizophrenic spectrum disorder. All of them have a break with reality. So psychoanalytically, how do we understand a break with reality? Anyone would like to take a... Yeah, please.
One cannot differentiate between self and object, where the voices are coming from within my head or they are coming from outside.
Right.
That could be one.
Yes. One situation. I see something which is not there. I have ideas of strange type. So what is the general first thing we look at? First thing we look at in any disorder is what is the symptom and what is the psychoanalytic story behind that symptom. So we are always looking for the psychoanalytic story behind everything. Does that mean everything has a psychoanalytic story? Most of the things have. There can be a few accidental things also. Not that we have one-to-one correspondence or a strict deterministic law of nature that this has to happen, but largely it is true. 75% of elements that we encounter in any disorder usually have a story or a part of a larger story. So schizophrenia spectrum disorders, here what we will see is psychotic disorders and schizophrenic disorders, the lighter ones and the difficult ones. So how do we differentiate the two? If we look at mild, moderate, severe, and if we look at this chapter and we say we are looking at moderate and severe, relatively speaking. Of course, compared to neurotic disorder, everything in this chapter is severe. But relatively speaking, within the chapter, we will say that in the psychotic disorders, something in the mind is crossing the line and after some time coming back. So there is a critical line and something is going on that side and coming back. Whether it's the Oedipal non-resolution, whether it is something anal or something oral, whether it is the work of ego or superego, whatever is going wrong for a short period and then coming back and then maybe repeating itself. Whereas in the schizophrenic spectrum, so from the psychotic disorder to schizophrenia form and schizophrenia form to schizophrenia, we see that increasing intensity, which means whatever is going over the line is taking more and more time to come back, and in some cases just not coming back. That's the broad understanding of a generic understanding of it. So now let's go into specifics. Okay, what is going on that side of the line and what is coming back? And that is specific disorder to disorder. So let us look at it. Let us take the first one. Delusional. So let us take delusions. Say first we say persecution. How do we analytically look at it? Anyone would like to try? Just think of oral, anal, Oedipal, component instinct, ego, superego. इसी में ही गेम है पूरा. हाँ सर.
The anal predominantly anal stage fixation or the dominant submission is the predominant struggle. And then I cannot tolerate my own feeling of, say, homosexuality. So I project it onto the other person and believe that they are making advances toward me.
Correct. Correct. So let us say when we look at erotomania, delusion of erotomania, then this will be one explanation. The second will be unresolved Oedipus. That I am projecting my desire onto the other and I believe the other is now falling for me. Similarly, delusion of reference. I feel extremely abandoned and inferior. I feel I have been put into a corner like a furniture and left over there, completely abandoned and dismissed. And the reaction formation defense is used to overcome that unbearable feeling of lonely abandonment. And then I come to the opposite of it, that everyone is talking about me. I am the center of attention of everybody. The delusion of reference. So let us say delusion of persecution. In Freudian terms, Freud describes it as unresolved homosexuality. So how do we account for it? I had said it once, if you remember. Do you remember the mechanism? Freudian mechanism of persecution? Write down if you want to. If you don't want to, it's there in the FAQ psychoanalysis. So the point is this. Freud says there is in the unconscious homosexuality, and this creates desire for the other. We will not go into whether the other stimulates the desire or the desire finds the other, because there is a problem there. In the Lacanian context, the object pathia is actually soliciting desire. He says desire is the desire of the other. It has two meanings. One, we desire what we don't have, so it's a desire of the other. Second is we learn what to desire from the other. And third is the other precipitates the desire. Like I am moving in the city, I had lunch an hour back, but I see something which I very much like to eat, and suddenly the desire comes in, and I eat it. If that thing was not in front of me, I would have gone without eating for half an hour more. So it was the object which precipitated the desire. But there are equally more number of cases where desire precipitates itself and then seeks out an object. But here we'll not go into those complications. We'll simply say there is a desire in the unconscious which is of homosexual nature. When it sees somebody who is likable, the unconscious movement happens, I love you. And the moment it happens, superego pounces upon it. So it's happening in the id. And the superego pounces upon it with its morality. It's not acceptable. And ego also pounces upon it because it may bring adverse remarks in the society. So then what happens is, because of that, the ego uses the reaction formation defense to convert I love you into I hate you. So I love you is converted into I hate you because I love you is unacceptable. If it is acceptable, rest of the things will not happen. And that is what we will do in healing. So I love you becomes I hate you. I hate you becomes, yeah, please.
The last part I did not follow. I love you.
I love you not acceptable to superego. The use of reaction formation defense, and we convert I love you to I hate you. Then as the love grows because of the denial, because the more you repress, the more it becomes stronger. So I hate you, I love you increases, so I hate you becomes I will kill you. One, because of the increased hatred, and second, because of all the discomfort it causes inside of you. That again is not acceptable to superego. So then the defense of projection is used to put it onto the other and say, he will kill me. And that leads to the paranoia, the delusion of persecution. So we use defenses twice. First is reaction formation, then projection. So that is the delusion of persecution in the Freudian terms. Klein will have a different explanation. When we go to Klein, we'll see it. Jung will have a different explanation. Kohut will have a different explanation. ISTDP will have a different explanation. So for every disorder, we will have 7 explanations of each of the schools. And obviously, patients will be in different groups. So the first is delusion of persecution. Then we can look at erotomania. The Oedipus is unresolved, and the rejection by the mother is unbearable. So the mother does not want me is converted into everyone wants me. You can also have a different route to it. Somebody falls for every woman he sees, and nobody responds to that person. And that is unbearable. And that also you can use reaction formation upon to convert everyone rejects me to everyone falls for me. So I have a psychotic constitution and I fall for every woman I see. Nobody accepts me, nobody reciprocates. So then I convert that I want everybody to everybody wants me. It's a projection. Delusion of reference. In oral stage or Oedipal stage mostly, if you experience very strong dismissal and abandonment, then the opposite of it is everyone is talking about me, everyone has attention on me. Megalomania. If the loss in the Oedipal phase is very severe, the castration is very severe, or the loss in the oral phase is very severe, or the control exercised in the anal phase by the parents is very severe, where one is made to feel extreme form of inferiority, powerlessness, then the reaction formation to that is used in megalomania. It's a reaction formation projection. First it's reaction formation and then projection. Two defenses are used sequentially. And essentially it's overcoming a severe form of I am not good enough. Some Freudians will also say, it is a way of becoming so good so as to have the mother. That I lost the mother because I was not able to match the father. Now I not only match him, I surpass him. And I become so great in my megalomania that it's an attempt to get back the mother. That if I am super megalomaniac, great, I can get back the mother. Slowly you will get used to this language. First time you hear it, you will feel that the person who's saying it is crazy. कि कहाँ की बात को कहाँ ले जाते हो, क्या कनेक्शन है दोनों में. But slowly it starts making sense in a metaphorical way. Grandiose type we talked about. One more route to the grandiosity is the route of narcissism. And there two routes are used, the route of primary narcissism and the route of secondary narcissism. Do you remember what they are? Both are in the oral stage, but do you recollect what we had discussed that day? Primary and secondary. Freud talks of two types of narcissism.
Primary is oceanic feeling.
Correct.
And nearly impossible, not nearly psychotic, whereas secondary is I don't remember. Fantasies of unlimited wealth, power, love, beauty, grandeur.
Correct. So the first is a natural state into which one finds oneself, rather a stage, to use Freud's words. So for Freud, it's a stage. You can safely call it a state, but for Freud, it's a stage. So that stage is a stage of oceanic feeling bliss, and it's a pre-object stage. You are not still having a clear idea of I and not I. And you are having an oceanic feeling coupled with bliss. And later, slightly on, after the object relation stage starts, you can experience secondary narcissism in the sense the child goes towards the mother or the father to have, or the caregiver to have an intense attachment. And that is frustrated, leading to a lot of pain. So the template that the child creates is, it is dangerous to get into attachments, better to be self-sufficient. So the emotion which is going towards somebody now gets invested in the self. And one also feels extreme rejection in that attempt, extreme inferiority, and that leads to the grandiosity. So when one is rejected, one feels extreme pain, extreme frustration, extreme anxiety of abandonment, extreme rage, and extreme inferiority. I am not good enough. And all of these are acted upon by defenses, leading to various symptoms of narcissism. So secondary narcissism. So unresolved secondary narcissism can also lead to grandiosity. But usually that will be with positive features. If it is primary narcissism, it is usually will be with negative features.
What will be with negative features, sir?
There will be withdrawal, what we call the 3 or 4 A's, anhedonia and all of that. There is loss of interest in pleasure. There is loss of interest in connecting to people, loss of interest in object attachment, and the general withdrawal, what we call the negative features. I forget those A's, apathy, anhedonia, I forget that list.
Abulia.
Yeah. Those 3 or 4 A's, I forget that.
And asocial something, I don't know. I'm not sure.
So that withdrawal,
Yeah.
and moving away from the object world. So that will have a larger component of regression to primary narcissism. And positive features with grandiosity will have secondary narcissism. And usually those who talk of primary narcissism, I mean those who regress to primary narcissism, they usually will bring in spirituality. So spirituality can easily be hijacked by the pathological process as a defense. That does not mean you cannot have pathology and spiritual movement together. Often they can be. That you can have a person on the spiritual path undergoing spiritual experiences, and as a part of it, certain psychotic things have come up. That's a very different thing. The psychiatrist Stanislav Grof, he calls it spiritual emergence. That category of psychiatric sicknesses, he says, are spiritual emergencies. So he advocates not medicating those emergencies. Will not go into how to draw the line and so on. But there has been some thinking on this. There is also a very famous book on this called Mad or Divine.
Or divine.
Mad or Divine. It's by one of the India's famous psychoanalysts, Sudhir Kakkar.
Oh.
So he talks about Ramakrishna Paramahansa and everybody. That what will you call his states of ecstasy? Will you call it mania, or will you designate it something else? Will you treat it, or would you like to follow it? Will you look down upon it as something abnormal, or will you look up to it as something supernormal? Or are we looking at something which is more confusing, that everything is together? that there is a supernormal part of the person and a subnormal part, both are going on together. So this is a slightly difficult area. So he has written a book, Mad or Divine. Yeah,
There was an article in a Sunday edition of Express or something 30 years ago. It spoke about Mahatma Gandhi, and perhaps it was written by Sudhir Kakkar. It says the sensuous ascetic.
correct.
The sensuous ascetic.
So many people have tried to analyze Mahatma Gandhi. Eric Erickson had come all the way to India for meeting and analyzing Gandhi. And recently, not recently, but I think about when I was undergoing training, let us say about 10, 15 years back, uh, there was a person who had come on a similar tour of India to understand Gandhi and psychoanalyzing. Because you can see a lot of Oedipal dynamics in his life. And many of the things he did were very difficult to classify. Will you call it a spiritual act or will you call it a perversion? So it's a very interesting thing to analyze it. One of the difficulties in that is because psychoanalysis has essentially grown up in the area of pathology. One of the limitations is we pathologize everything. That is a limitation we have to be careful about, not to blanket pathologize everything. Jealous type. Delusion that the spouse or the lover is unfaithful. It's a leftover from the Oedipal defeat that the mother has got to the father. It's a betrayal. In practice, this is terrible when it comes up between husband and wife. I came across one of the cases where this was continuing for last 20 years. And for 20 years, the person has been obsessed. It's a combination of OC and delusion both. That why did that person say this or make that call on that particular day? And the same story repeats. And occasionally that OC goes into this psychotic realm. Persecutory type we have dealt with. Somatic type. This can have roots in the anal phase, trying to control the body too harshly or not trying to control the body, or you can have it symbolically. For example, let's say a somatic delusion. Okay, let me take an example. One of my supervisors took a person had a uh, not delusion, but I just hallucination example. He had a hallucination that insects and cockroaches are crawling inside the body under the skin. And slowly, this number of those who are crawling is reducing. And therapy was on, medication was on. And finally, he said, there is now only one cockroach who is moving inside. And my supervisor said that this man is going from positive aspect of this psychosis and schizophrenia into a negative aspect, very soon this cockroach will also go away. And that is where this man will withdraw completely. It will be difficult to catch him either in therapy or in medication. The prognosis is very bad. So in his case, that was, if you talk of life and death instinct, that was the only symbol of the life instinct. And the life instinct was slowly yielding ground to the death instinct. So whatever movement was there, no matter how ugly the movement was, and if you go deeper, the cockroach also is an example of his own self, his own parts which were moving. Like there is a very famous book, Metamorphosis, by Kafka, in which slowly he becomes a cockroach. That kind of self-loathing, self-anger, anger towards oneself, all of that was there. And parts of him were still moving with life, no matter how ugly they were, how loathsome they were, how unsavory, unacceptable they were. But slowly even that was coming to an end. In a way, the disappointment in the world was getting complete. So how deep the disappointment goes, that's very important. If the disappointment is complete and hope is extinguished, it's a very difficult situation. Bizarre content, bizarre delusions when you have things from oral, anal, and all these things coming together. Let me give an example and then we can break for a cup of tea. I was taking a case in civil hospital many years back. This person had this bizarre delusion. The delusion was that in Ahmedabad, there is an area called Hanuman Camp, and near to that area, there is a military cantonment. The man had a delusion that there is a group of military officers in that military cantonment at Hanuman Camp who have such devices that they can extract thoughts from my head. And they also have such devices that these devices, if they fire, they can vanish and suddenly appear above his head and get into it, tearing it apart. And he talks often to a religious figure in his head who helps him. And when he helps him, these people are not able to do anything. But now somehow the religious figure is no longer helping him, and he has refused to help him anymore. He has helped him many times over. So now he does not know what to do with that thought extracting machine. And if they get into him, if they kill him. So we have here a bizarre kind of a story where you have a persecutory element. In some cases, in some parts, you will have megalomaniac element. In some part, you will have a terrified person. In some part, you will have Oedipal castration. In some part, you will have the anal rage projected outside. The anal sadism of punishing somebody very viscerally in a gore-some fashion. All of that is there. So you will have here the oral rage, the anal rage, the Oedipal rage. The defense is used on those events to project things outside. And the sadistic thoughts he had for the father now been displaced onto this person. So what he would do to the father, now this military officer who is the father figure, the authority figure, will do to him. So this is a kind of a very hodgepodge kind of a collage of a bizarre kind of thing where multiple things will come together. Yes, Madhusudan, you had a question?
Sir, just one question. Did he give a name to this imaginary guru of his? Did he have a name?
No. In fact, I asked him. He would
Yeah.
not give name to any of those characters, not even the military officers.
So that fits perfectly into the Lacanian psychotic. The unwillingness to position uh, these figments of his imagination in the symbolic. So otherwise, to put them into the symbolic means to give them to accept the power of society of the symbolic. Whereas the whole basis of psychosis is the belief that there is an other to the other. There's something beyond society that's running things. So this is military. It's not, it's not patriarchy. It's not the phallus. That's how it is. Yeah.
Correct.
Yeah. Thank you, sir. Yeah.
So this is like uh, a Freudian thing where we say that those are the authority figures, father figures, and because you want to do so many, you wanted to do all these things to your father. Now you feel you are not successful, they will do it back to you. So instead of the father doing it back to you, now these officers will do it back to you. And you also see the omnipotence being projected. That they have this machine, they have all these magical things. So we also see a very important component of omnipotence coming in. So omnipotence, although Freud does not talk about it, so we won't bring it in at this point, but omnipotence is a very important element in personality disorder and psychosis. That either the other is omnipotent or I am omnipotent. So for the narcissistic personality disorder, the self is identified with omnipotence, so I am omnipotent. Independent, it is projected on the other, so I am de-idealized and the other is omnipotent. So the dependent projects omnipotence on the other and de-idealizes oneself. The narcissist projects omnipotence on oneself and de-idealizes the other. But Freud has not talked about it, so we won't bring that in. But the Freudian idea will be of the anal story, the oral story, the Oedipal story, somehow getting together in this bizarre delusion. So some component will have anal story, some component will have Oedipal story, and an oral story, and all of that put together will create this so-called difficult to understand bizarre delusion. But any bizarre delusion is like a strange dream. And just as you analyze a dream, you can always analyze a bizarre delusion. It's not bizarre actually. It's bizarre at the surface. You will find very few bizarre delusions which are really bizarre. In the sense, you can say that there is no psychoanalytic story here. It's just the misfiring of chemicals.
Firing off.
Misfiring of neurochemicals. That you cannot say, regardless of how much you try to apply your knowledge, you can't find a story. There will be very few delusions of that type. In most cases, you find a story. Should we break for a cup of tea? Yeah.
What happened to the person with the last cockroach under the skin?
Huh. This person, that the supervisor was of the opinion that that person should be given more of medication and less of therapy. Therapy will not be able to hold back the deterioration which the process is undergoing. It's too rapid, too strong. You can't hold it back by therapy. So he was, of course, he was in medication, but they became more aggressive in medication. And then therapy continued for some time and then he stopped coming. And then the story became very interesting. He stopped coming and this went on for about 2-3 years. And after 2-3 years, somehow he started going back to work again. Not to a company, he had a shop kind of thing. He went back to his shop, his father's shop. He started going back to the father's shop. And Thereafter, after some time, he left medication also. The withdrawal to a great extent was there, but he was able to go to the shop, do something. Occasionally it would flare up, occasionally he would do something strange. And this continued for about 1.5 years. After that, I was not in touch with him. I don't know what happened to that person. Similarly, there was another case of a person who was in a medical college, and that person was treated for depression and schizophrenia, and then came for therapy for a few sessions and then stopped. But somehow that initial medication and then a few sessions of therapy, and then the person stopped both of it. But fortunately, the person got better, and he was able to complete the medical school. So this is very strange, because then I got another reference, because this person felt better. They thought it was because of therapy, which
So,
was
sir, has it ever been possible that you have, without medication, been able to help somebody who is going through psychosis
psychosis.
or like schizophrenia or delusions?
Yes.
Okay. Because usually we think that only with drugs we can give the therapy and it can help, no?
That is better, actually.
Okay.
That is better, because there are two parts. One, where it becomes extremely florid and acute, there is no way out but medication. That is one part of it. Second part of it is, even when it is not acute, it always gives better results if both of them are together. But what happens is, and this practically happens very often, many people who are diagnosed with schizophrenia, they take the initial medication, because when they are diagnosed, it's an emergency situation. So practically the family has taken them to the hospital and so on and so forth. So they take the first 1 or 2 months of medications. It may involve ECT, it may involve whatever the situation is. After that, they want to get off it. So to get off medications, I'm not talking of everybody, but one group, they come to therapy. In therapy, they continue for usually for a month or two. And somehow, the moment you start going deeper, and the moment they start developing an attachment, or some strange fantasy comes up, they find it very difficult to continue. It can also be because you are not equally skilled, adequately skilled to handle those situations. Probably you are going too fast, and it's beyond the bearable limit. But then what happens is that many of them give it up. But because of what you have done in the few sessions, in the sense of probably they have got to know the cause of what they are suffering from. They know what they ought to do. They may not have done, but they ought to do. So then often many of them continue for some time without anything. So I at least know a couple of people of that group. There is another group which stops therapy and goes back to medication.
Oh, okay.
For that group, the journey will be from medication to therapy and back to medication. And usually they don't come back for therapy. Different group. And it also has to do with certain things which you never think of. For example, let us say a Freudian patient of delusion of persecution comes, and you are a male therapist. Now, one of the very risky things to do is to do that therapy on the couch. because the patient is lying down on the couch and you are behind the patient, he can't see you. And if the homosexual dynamics are on and the patient is a man and you are a man and you are in that therapy room and everything is closed, both of you are together, it leads to very difficult unconscious fantasies. And you will see often that the patient will sit up and sit on the couch. He won't lie down. And that's a danger signal, because if it continues for a long time or it repeats, he will stop coming to therapy. So in those cases, the gender also makes a difference. That if you have a delusion of persecution based on a Freudian type, it's better to have a therapist of the opposite gender.
Yeah, thank you, sir.
I lost many patients because of this.
Oh,
I never knew what was at work. Later I found out.
so can I ask another question there?
Please go.
So what would have been the ideal thing that if you wanted to still work with that patient, what would be the ideal change that you would bring about in the dynamic?
Two things. One, I lost a few patients because I thought it was too early to go in for interpretations, and I was in the holding mode when I should have been in the interpretation mode. It was one. So my supervisor told me, when I discussed, after I lost the patient, I took it to the supervisor. So he told me many years back, this is there, he told me that the therapist is absent in the room. That in your quest to make him more comfortable, you have not intervened enough and rightly. So the therapist is absent because what is troubling the patient, the therapist is not addressing that with adequate authority and power, not in the jingoistic sense, but in the soft, firm sense, assuring sense.
Yeah.
So that was one. Therapist was absent. That was one lesson I learned. The second was interpret that, taking the risk of it being still too early. My mistake was I thought it was too early to make those kind of interpretations. My idea was that let a few sessions go and then we'll go to that difficult area of homosexuality. But that was a mistake. I should have interpreted. If it was interpreted and discussed out, probably the patient would not have left it. Left therapy, left me rather. Third was about the anxiety, the safety and holding. I was too young. I did not have that containing capacity to really be calm in the face of anxiety. So obviously, I must have experienced the anxiety he was experiencing, and that his unconscious would have made out that I am also equally affected by that anxiety, and I don't have the containing capacity. And this is completely unconscious. I mean, he won't know these words, but he will just know that this is not the right place.
Okay.
This is how often we lose patients when we start off. We all lose.
Yes. Okay, thank you, sir.
Any questions? Yeah,
So
please.
just a comment. I thought that psychoanalysis also must be having a therapeutic window.
Correct.
There must be some effects beyond a range. And for some patients, it becomes intolerable. And for some patients, the dose becomes low.
Correct.
So when to interpret and how much to give, it's all,
So
not everything is defined.
So we will take that up when we do the technique.
Yes, sir.
When we do the technique lectures, we'll take up those parts, right? How to do therapy, when to hold,
Yes, sir.
interpret, what to do if the process itself is unbearable. Not what you are saying, what you are interpreting, but the process itself is unbearable. That lying down on the couch itself is unbearable. So those are very difficult things so when we take up the technique lectures, then we'll look at this frame. That should we do it on the couch? Should we do it face to face? How much self-revelation you should do? or should you be completely anonymous? How much to hold, how much to interpret, how, because language is very important here. Like somebody who is extremely regressed uh, in schizophrenia or psychosis, and you use something metaphorical. Like I remember one of the supervisions, I was seeing somebody else, and the therapist said, "Don't you think you are still held back by the ghosts of the past?" And the person started looking around as though there are actually ghosts. And then in ISTDP, somebody was saying, if you don't put up this wall of resistance between you and me, can we not have a more authentic therapeutic relationship? So the patient said, where is the wall? I don't see it. So, because what you are saying metaphorically, he is taking it concretely. So that how much metaphorical can you go? That's also a very important thing, because in extreme regression and concreteness, it's very difficult to, I mean, you really have to control the language.
Language is a transitional object.
Yes, because they can't play. In a sense, they are in the real,
Yes.
in the concrete world.
Yes, sir.
That is one part. And the worst part is when they have made a private language. That's even worse. Where when they say chair, they mean table. It's a private language in which they are operating. It's even worse.
Yes, sir.
4 o'clock. Let's get
Yeah.
to 10.
4:10. Okay. Thank you. We'll have a new connection.
Ah,
Yes.